Good morning, everybody. My name is Bjorn Meijers. I will be the chair of this session, and I will start with an introduction. During the opening ceremony, Prince Daniel, the future Prince Consort, gave a strong patient testimony, and he provided us also with some tips how to proceed. And one of his tips was think about individualization of therapy. And that exactly is the topic of this session. Individualization in dialysis. Is this a new practical approach or just wishful thinking? This year's ERA meeting also marks the one-year anniversary of the publication of the main results of the CONVINCE study. And despite some debate remains about potential biases, including by the COVID pandemic, these authors, researchers, patients, nurses, physicians should all be heralded for the completion of the study in such difficult times. The CONVINCE study really nullified the futility argument of doing clinical trials in a complex setting in patients on maintenance hemodialysis. This study shows us we have the power and the tools to shape patient outcomes. So we should start thinking about what should be the goals of our next clinical trials. What are relevant outcomes? And it was exactly this question that we in the SONG HD initiative aimed to answer. I was one of many healthcare professionals completing 3 rounds of questions rating individual patient outcomes. And together we as physicians identified mortality as a top 3 priority for future clinical trials. However, when patients and caregivers were also completing 3 rounds of questions, they did not indicate mortality as a top priority. It was not even in the first quartile of priorities. Instead, they focused on ability to travel, dialysis-free time, and less fatigue. And so the question is how to reconcile this apparent discrepancy between the vision of physicians and the vision of patients they treat. On a very high level, one might say that doctors are always busy to optimize mostly the future of the patient, while patients that are confronted with their day-to-day issues are more busy optimizing their present. It's worthwhile to take a closer look at how we came to this. The SONG initiative was a multi-step process, and it started all with a literature review, and a long list of potential outcomes were listed. And then all groups, physicians, patients, and caregivers were asked to rate them. Now, one aspect of this is hidden in plain sight. All of these candidate outcomes should be intrinsically important to the majority or even all of the patients. So by design, it left out relevant outcomes that happen not in the majority of patients, but in a smaller subset of patients. But that does not mean that these outcomes are not relevant for that specific patient. Let me illustrate this with 2 cases. First case is Ben S. He's a male of 33 years of age. He's in kidney failure, treated with hemodialysis, and his underlying disease is X-linked Alport syndrome. His dialysis vintage is 31 months, and he's waitlisted for kidney transplantation. Now, the second patient is his twin brother, Ken. The parents were very original with giving the names. Evidently, he is also 33 years of age, and kidney failure, same underlying disease, slightly different dialysis vintage, also waitlisted for transplantation. However, this patient developed an upper GI bleed, and on gastroscopy, an ulcer bleed was diagnosed. So we now have 2 patients from the same family with an identical genetic background, with the same patient history. Should we conclude that all endpoints for these patients should be identical, or should we think about treatment individualization? We know that hemodialysis is associated with a higher risk of bleeding. This has been known for decades already. But in a number of recent studies, it indicates that the risk of bleeding is not only higher than the healthy population, but the risk in patients on hemodialysis is also higher than patients that are treated with peritoneal dialysis. I will now quickly introduce our faculty, which will provide us hopefully with some answers on this. First is Professor Patricia Teixeira. She's a professor of nephrology in the University Hospital Infanta Leonor in Madrid, and she's also associate professor at the Complutense University, also in Madrid. The second presenter today is Professor Sunny Eloot. She has a background in civic engineering, but devoted almost all of her professional career to development and testing of different treatments for patients with kidney failure. She currently holds a position in the nephrology unit at the UZ Ghent, and also is a professor at the engineering department and past president of the European Society of Artificial Organs. I will now first give the floor to Patricia. Please, welcome.
Good morning. It's my pleasure to be here today. And first of all, I would like to thank Nipro for the invitation and for thinking of me for this symposium. As you can see, the topic of my talk is about enhancing dialysis outcomes, strategies for improved patients' survival. Sorry, I tried to, oh yeah. These are my conflicts of interest. And I would like to start with this fantastic graphic from Professor Bernard Canot that shows us the advance in blood purification by extracorporeal therapeutic options. And I will refer to some of them, the treatment efficiency, not only hemodiafiltration, but also expanded hemodialysis, also the dialysate with citrate, and also the individual electrolyte prescription. And in summary, these are the three topics of my talk: the dialysis technique, the dialysis fluid, and the membrane. As you know, despite the progress in the technology in dialysis in the last 30 years, the mortality of our patients is extremely high. This is the survival in 5 years in the ERA registry in 2015, and you can see 42 patients survival in 5 years. This is worse than some of very common cancer like breast cancer or prostate cancer. So it is clear that we must improve this so high mortality for our patients, and the technology must improve also. And here, as you saw, the evolution of hemodialysis, I put the hemodiafiltration and expanded hemodialysis like a big efficiency or great efficiency technology for dialysis. High removal performance. And if we want to decrease the mortality in hemodialysis patients, we have to refer to hemodiafiltrations, because as you can see in the slide, different prospective randomized control with the objective of survival has demonstrated that we can improve survival in our patients, but we must take into account that it would be volume dependent. So it seems that with hemodiafiltration, there is some molecules or some toxins, probably that higher molecular way, that we can eliminate, and this would represent for patients to live or to die. But the million-dollar question should be if we can decrease mortality also with this new technique with expanded hemodialysis. And theoretically, we can say that yes, because with this technique, we can eliminate more uremic middle molecules like we do with hemodiafiltration. And what is my point of view? I see the expanded hemodialysis like the little brother of the hemodiafiltration. It just has been born, it's little, but it looks very well. But we don't know if this little brother will be taller, will be shorter, or the same height that the brother hemodiafiltrations. For that, we must wait. We must have prospective, randomized, and controlled trials to demonstrate which is the position of the HCX between HDF. And I would like to highlight this study carried out in Japan. Is from the Japanese Dialysis Registry, and they found a correlation between mortality and the type of dialysis. And you can see the classification of dialysis are different between Europe and Japan. In Japan, they classify in 5 groups depending on the beta-2 microglobulin clearance, and the 5th or super high flash dialysis behave like a medium cutoff membrane. Here you have the 3 years mortality risks of the patients, and as you can see, the mortality decrease as the clearance of beta-2 microglobulin increase, and this is adjusted for different basic factors. And also, I would like to show you the only meta-analysis that compares the 3 techniques, high flash hemodialysis, expanded, and hemodiafiltration. Include 29 studies, but only 13 of them were randomized controlled trials, and only just one was compared hemodiafiltration with expanded hemodialysis. The follow-up was very different between the studies, and in conclusion, they say that the efficacy and the safety of hemodiafiltration has a strong evidence, including several randomized control studies, as I showed you. While HDX may offer benefits over high flash, but we need long-term studies. The only study that compares hemodiafiltration versus expanded hemodialysis is the only one, but they found no differences in survival, but only 40 patients each branch, only 1 year follow-up, and mortality was the secondary objectives. And obviously, all of us want to take evidence, want to have evidence, but the evidence takes time. And let's not forget that the first clinical and microbiological trials of hemodiafiltrations were conducted in the 80s, randomized controlled trials studies, the first in 2020, and the last in June, you know very well, the CONVINCE, and there are still ongoing studies analyzing the mortality between hemodiafiltration and high flash. So to fill this gap, we conducted in Spain this study. The MADER study is a multi-center open-label prospective randomized to explore the morbid mortality in dialyzed patients, comparing HDS with online hemodiafiltration. The design of the study has been published in the Clinical Kidney Journal, and as you can see here, the composite primary endpoint, where HDX is non-inferior to post-online hemodiafiltration in global mortality, cardiovascular mortality, and cardiovascular events. And what happened after the randomization to HDX and HDF, we have a big follow-up, 24 months with follow-up, and we make analytical data every 3 months, and a survey or quality of life survey every 6 months. And here I saw the preliminary data that were presented the last era about the MADER study. And you can see in red the HDS with Terranova and in black hemodiafiltrations. And the primary endpoint were all cause of mortality and the cardiovascular event, stroke, coronary syndrome, peripheral artery disease, and colitis ischemic. And as you can see, there is no difference in this moment between the 2 therapies. And also here the mortality, the same in red HCX and in black HDF. Here are the different causes of death. We include also the COVID-19 because the study started in 2019. Well, the second component in the dialysis treatment that we can tailor our patients is the dialysis fluid. And I agree with Flanagan that the dialysate is the drug central to uremia treatment, and that we must individualize the electrolytes, sodium, magnesium, calcium, bicarbonate, but not only the electrolytes, also the citrate and the acetate. No? The most popular acid used in dialysis is the acetate in concentration from 3 to 8 millimole liters. But we can also use citrate. We have two kinds of citrate. One is only citrate, 1 millimole liters, and the other is citrates, 0.8 plus a little amount of acetate, 0 plus 3. And we have conducted a multi-center study in Spain, and one of the conclusions of this study was that the magnesium decrease with citrate, decrease the calcium. That means that the citrate not only chelates the calcium, but also the magnesium. And we asked for the different company to increase the concentration of magnesium. And we have here the citrate with a higher concentration, 0.75 millimole liters of magnesium. And also this is one study that was conducted in my hospital, and we find that with citrate we have a 33% significant better survival in this follow-up, 25 months follow-up study. This is a retrospective study. And then this is the study I refer that was a multi-center prospective randomized study. And we have published the results, both the acute and the chronic effect. And I would like to show you just one or two results. Well, this is the design. All of patients were, it was a period with acetate, and they were randomized to citrate or acetate cross. And I think one of the most important things of this study is that this is the longest study with citrate. That was 8 months, and it's very difficult to have 8 months patients in one hemodialysis study. And this is the main result, in my opinion, that we found with citrate less hypotension. You can see here more than 4,400 hemodialization, and we found a 25% reduction with citrate. And here in this summary table with the situation in which hemodialysis patients could benefit from using citrate, where you can see hemodynamic stability, low PTH or adynamic bone disease, I think is very interesting for this kind of patients. Patients with an indication to reduce heparin or dialysis without heparin, of course, alkalosis, metabolic, malnutrition. And with NA here in this table, I put the situation that supported by the result of our work. Not all these things have been supported by our work. Well, and the third topic is related to membrane. What will we do with the patient that cannot use the full dose of heparin or cannot use heparin because has an allergy, for example? And I will show you results from the cellulose triacetate in this situation. Well, how do guidelines recommend dialysis for patients at high risk of bleeding? Most of the guidelines recommend flashes with saline and also regional citrate anticoagulation. But also in the era, prostacyclin infusion, UK also include high blood flow rate, in USA citrate dialysate. Japan and Australia done other important things, and also in the Netherlands, the hemodiafiltration in predilution. But really, this is a very common problem, and it's not solved. We have not a formula to solve this problem, so we wanted to investigate this, and we conducted this study, the SOLFA study, also prospective, multicenter, and randomized and crossover in patients in dialysis, in high flash, and also in post-dilution online hemodiafiltration. And the principal objective was to evaluate the impact on the thrombogenicity of these dialysers with respect to other synthetic dialysers that we use in our dialysis facilities. And the secondary was to assess the effect of decrease or stop heparin on hemostasis time, on dialysis efficacy, on the feasibility of hemodialysis. And also, in a subgroup of patients, we analyzed the coagulation fever by computed axial tomography. The other analyses were with a visual score coagulation. Here are the inclusion criteria, like all the studies, and I would like to remark the exclusion criteria, the synthetic membrane allergy and heparin allergy, obviously, and patients with oral anticoagulation, the design of the study after randomization to triacetate cellulose or the synthetic membrane. And we have two phases, one with every dialysers, and as you can see here, we reduce the dose of heparin progressively. The first session 10%, 75, 50, 50, 25, if it is possible, in the sixth session, heparin-free dialysis. And these are the principal results. You can see that the percentage of sessions without heparin was 60% with Solathia and 24% with synthetic dialysis. So, in conclusion, the viability of the membranes when we reduce the dose of heparin is greater with Solathia membranes than with commonly used membrane. This was made with a score, a coagulation score, that was the addition of the chamber score and the dialyser score. And these are the photographs from the dialyser, the section, the cross-section of the different dialysers. Here we compare Polyflux and Solathia. And as you can see, with more fever are coagulated, are more white, and with more open fevers, with Solathia are more black. No? Also, we can take the number, exactly the number of fevers that were open with the CT scan that was made in Ghent in the Sunny Elot Hospital. So I would like to give you three conclusions, each for each topics. The first one about dialysis technique, expanded hemodialysis. I think that is a new technique, a new renal replacement therapy that is sure better than high flash hemodialysis, but maybe is equal, or we will see which position between HCX and HCF. And I think that the mother study probably will put light in this. In the second, the dialysis fluid citrate is a very good option for some patients, and has beneficial like hemodynamic instability, alkalemia post-dialysis, and a dynamic bone disease. And the last is that we have a low thrombogenic dialyser, Solathia, for use in settings with reduced or no heparin. And the last message I would like to give you is that the best treatment is the one that each patient needs, each patient a technique, a dialysate, and a dialyser. Thank you very much.
Okay, we now move on to the next speaker, and after the second presentation there will be time for questions. I can imagine there will be a lot from the floor, or at least that we all hope.
Good morning, everyone. It's a pleasure to talk in the symposium. And within the symposium about individualization in dialysis, I will talk about individualization of anticoagulation strategies and how anticoagulation will impact the dialyzer fiber patency and the quality of life of the patients. In a recently clinical study, including 70 of our patients, we measured the fiber patency after dialysis, and by setting this versus the anticoagulation dose normalized per body weight, we found out that 3/4 of our patients had good patency of more than 70% open fibers, which was good news. But as you can see, there are a couple of patients who seem to be over-anticoagulated, and possibly they could be dialyzed as efficiently with a lower dose. On the other hand, we also see a couple of patients which seems to be under-anticoagulated and who really need a higher dose to get a better fiber patency. But maybe one of the most striking things of this figure is that there seems not to be a correlation between the fiber patency and the anticoagulation dose. And this already points to the importance of other factors that play a role in the clotting. As you can see from this picture recently published in a special edition edited by Professor Meyers in Seminars and Nephrology, we see that there are a lot of, clotting and anticoagulation have a major impact on the patient. We distinguish between physical and mental outcomes, and with physical, we can have interrupted sessions, patient might lose his blood, the adequacy of the dialysis will be lower, patients will get anemia, and so on. And also, together with the mental outcome, this all results in a diminished life participation of the patients. So really pointing out that it is important that we unravel the clotting and that we have a better understanding how to anticoagulate. Now, before we start the session and want to anticoagulate, the problem is a bit that we don't have hard evidence on how much this dose should be. And even if we would have an idea, we can never extrapolate it to all our patients, since there is a big individual difference. You have patients which are have more inflammation than others. Other patients take medication. That all plays a role. On the other hand, you also have the dialysis machine and the therapy itself, which also enhances clotting with, for instance, the blood-air contact and all kinds of forces acting on our blood cells. Besides that, while in the general healthy population we have a nice balance between clotting and bleeding, in our dialysis patients we see that some patients have more tendency to have bleeding, mainly due to the medication they take, and other patients might have have a higher risk for clotting, for instance in case of inflammation. Besides the patients, also in the circuit we distinguish different items, like high shear mainly exists in the cannulas or the catheters. The mechanical trauma is most prominent in the pump segment, where the rollers are really might smash the cells. We have the blood-air contact in the venous air trap, and of course the dialysis membrane with around 2 square meters in surface area has the highest risk for issues related to bioincompatibility. So, back to the situation, we need to anticoagulate. And it would be great if we would have a kind of a parameter that tells us something about what should the dose be. While different biochemical parameters, clotting parameters, were found interesting in the general population, For hemodialysis patients, up till now, we have no parameter that is really correlating with the outcome of the dialyzer. Also, it would be great if we would have a parameter on the dialysis machine that alarms us when clotting is going on. But even there is no hard evidence. And up to some years ago, the only thing we could do was do a visual inspection of the dialyzer post-dialysis. But the visual inspection is depending on the operator. It's also depending on how the clotting is distributed in the dialyzer. And it's also a bit difficult because of the different housings we have. We have dialyzer housing, more milky or clear polycarbonate. So also there, we don't have the best parameter. So looking at all these problems, I now come to the different research questions I will discuss. I will first present you a reliable technique to quantify the dialyzer fiber patency. And with that technique, we have done different clinical studies looking at the impact of anticoagulation on quality of life and bleeding, also on the membrane thrombogenicity, and on the fiber patency in different dialysis modes. Finally, I will show you some slides about how clotting is progressed during the session and overall what the clotting has as impact on the final solute removal. So first, we used micro-CT scanning for our hemodialysis to have an idea about fiber patency. And this technique was validated in a study in 20 patients. So we collected the dialyzers after the normal rinsing back procedure. The dialyzers were visually scored. They were further dried with some positive gentle airflow, and the dry mass was determined. And then they were sent to the micro-CT scanner. The scans were done with Hector. That's a high-energy CT scanner, which is optimized for research. It's an in-house scanner of the Ghent University, and the resolution is 25 micrometer. So knowing that our dialyzer fibers are 200 micrometer, then with this scanner, we have at least 30 voxels per fiber to visualize that fiber. So it's a very accurate way of visualization. Our dialyzers are mounted in molds on a rotating plate to take the scan. And while turning over 360 degrees, around 20 minutes, we got 2,400 projections, resulting in a three-dimensional picture, and of which we can take slices. We have chosen to visualize the potting because there we have the best contrast between the polyurethane, which seems to be gray on the CT, and the fibers. If they are filled with air, they are like black dots. If they are filled with clots, they are gray as well. So in dialyzers, like you see here, the white space are clotted fibers, the black dots are open fibers. And these circles can be counted easily in a freeware program, ImageG, which is also used for cell culture counting. And knowing the number of fibers in a used dialyzer, we can relate that to the total number of fibers in a dialyzer, and then we have the percentage of open fibers. So knowing this number of open fibers, we can look to the correlations with mass and visual scoring. And even though visual scoring is a non-continuous variable, we have found a correlation. On the other hand, we also checked different machine parameters like venous pressure, arterial, transmembrane pressure, online clearance monitoring, but none of these parameters was found correlated with our results of the CT scan. In a second part, we will look at the impact of anticoagulation on quality of life. And for this, we included 70 patients. They were followed during 8 weeks. And at week 0, we collected their dialyzers and prepared these for micro-CT scanning. And beside that, we also questioned the patients about bleeding. This was done with the ISTH bleeding assessment tool, asking about all types of bleeding during the past month. And we also calculated the risk for bleeding with the Hasbled score, with all like hypertension, drugs, all risk factors for bleeding. Beside that, we also looked at the limbs of the patient and we counted the bruises and hematomas. For the quality of life, we questioned the AQ5D questionnaire and also asked the patient to rate their well-being on a scale 0 to 100 using the visual analog scale. At week 4 and 8, we repeated the bleeding and quality of life questionnaires just to see if there is consistency in the story. What can we see? That if we look at bleeding, the majority of our patients are doing well, but still it was quite astonishing that there are patients with a lot of bleeding signs, like patients with more than 20 bruises, of which we were not at all aware. And if we look at quality of life, the VAS score, this was even correlated with bleeding and the amount of anticoagulation. And by doing a cluster analysis, we could really find 2 groups in our patients. One, 49 versus 21 patients. And in this latter group, we found that they had a higher anticoagulation dose. They, although borderline, they also had a higher fiber patency. Due to that higher anticoagulation dose, they seem to have more incidence of bleeding and a lower quality of life. So this really stresses the importance of doing a good anticoagulation because of the impact it has on bleeding and quality of life. In the next step, we look at the impact of anticoagulation on membrane thrombogenicity. In this study, we included 10 patients which were followed up during 4 consecutive midweek sessions. And there was randomization for the membrane, either the Solacea from Nipro or the FX800 from Fresenius. And we also randomized for different doses of anticoagulation, the regular full dose or the half the regular dose. So on the right, you see the micro-CT scans. 1 row is always 1 patient. You see here 5 out of 10, just randomly. And in each column, you see 1 study arm. And as you can see, Solacea seems really promising. Even with half the anticoagulation dose, nothing has changed in openness of the fibers. With respect to the dialysis dose, we all know that post-dilution HDF causes hemoconcentration in the dialyzer. And then we have a kind of a gut feeling saying, okay, this might also result in enhanced clotting. So that's why we wanted to put numbers on that gut feeling. And besides hemodialysis, we also looked what's happening in post-dilution hemodiafiltration with 80 liters of substitution, and what's happening in pre-dilution with 36 liters of substitution. We included again 10 patients. Now they were followed 6 consecutive midweek sessions. We had a randomization for the dialysis mode, so the 3 modes, and also for anticoagulation, a quarter and a 0. All these tests were done with the Solacea, and we knew from before that half an anticoagulation dose did not give any problem, so we really had to go even lower, down to 0, to get to significant differences among the different modes. If we translate these scans into numbers, on the y-axis, you see the relative number of open fibers. On the x-axis is actually how much is a fiber open. But let's say, look at 50 to 70% open, then you see that for a quarter of anticoagulation, there is no difference between the three modalities. And even the dotted lines, if we look for the with zero anticoagulation, it seems that the post-dilution hemodiafiltration is equally effective with respect to fiber patency as pre-HDF and hemodialysis. We were also a bit interested in how is clotting now enhanced during a dialysis session. And for that, we included 10 patients, followed them up 6 consecutive midweek sessions. And to know how is clotting after 1 hour, we stopped the session after 1 hour. And another midweek, we did a dialysis of 2 hours. And finally, also a dialysis of the full 4 hours. As you can see already from the graphs, and especially if you look at the pictures of the scans for the FX, you see that most is happening during the second half of the dialysis session. So that means clotting is not at all a linear process, but is more accelerated near the end of the session. But after all, we are of course interested in how this all impacts clearance and removal. And as you can see, the extraction, so the relative clearance in a dialyzer, is really depending on fiber patency. If we have open dialyzer, we have high extraction, which is lowering for more clotted fibers. If we look in time, we see that the Solacea has a constant extraction, which is of course in line with the open fibers, while for the cardiacs, the extraction is going down from half the session to the end of the session. Now, okay, instant clearance is interesting, but after all, we are more interested in how many solute did we really remove from the patient. And for that, we have to keep in mind that during dialysis, the blood concentration of a solute is going down. So in the beginning, we have a high concentration, and that means also a high removal, while near the end of the session, concentration is lower, so the amount that we can remove will also be lower. So that also means that if clotting only happens near the end of the session, this might also only have a minor impact on the overall clearance. And this is also what we see, especially for small solutes. For instance, phosphorus, at the end, total solute removal is negligible difference between the Solacea and the FX. For bigger molecules like myoglobin, however, we found a bigger difference. So to answer the research questions, we have now a good technique to really quantify fiber patency. It's really, it was really frapping that anticoagulation has an impact on the quality of life. So we really need to go for lower anticoagulation or better membranes. With respect to the membranes, we saw that the Solacea is really successful, even with zero anticoagulation. And we learned also more about different modes, how clotting is progressed, and the impact on removal. Now, where are we now? Okay, we have now a micro-CT technique to get an idea about what should be the anticoagulation. But still, this is in a research setting. So this is still a bit following facts. And it takes at least 1-2 weeks before we get results and so on. But in the meantime, we still don't have a biochemical parameter. So what could be one of the next steps in our research is that we go for a micro-CT scanner, which is much smaller, which is maybe also less complex, and which could be used within the clinic. And if we would have that, we could do research, clinical studies with a much higher throughput, or we could even use it in clinical practice. For instance, if we have a an outcome of dialysis, as shown here, with some of them more clotted than others. By doing micro-CT, especially in those where you think there were problems, you could already adapt the next dialysis session, the anticoagulation dose, so that you end up with open fibers. As a take-home message, we saw the impact on bleeding and quality of life, so we really need to go for lower anticoagulation doses or better membranes. One good tip is that you track the anticoagulation doses, especially after episodes of, for instance, inflammation where you have increased dosing. Afterwards, please take care that you decrease it back to where you started. And with respect to the membranes, we saw that the Solacea is really superior, not only versus the FX. We have done different other studies, also in a bigger portfolio. It's really the superior dialyzer right now. So still a lot to investigate, still a lot of questions, but with these two tips, these might us help already much further. I want to thank my team for the help in the clinical studies and you for listening. Thank you.
Thank you for two lovely presentations. I'm just looking around if there are already questions from the floor. Online we also have a good attendance, almost 50 persons, but there are no questions online. Are there questions in the room? Yeah, there's a person, okay.
Hello, I'm Dr. Vidal from the Philippines. This is for the second speaker. I just want to ask if, for those patients you have enrolled in your study, were they first-time dialysis patients or were they on chronic dialysis already?
They are all stable chronic hemodialysis patients.
Chronic hemodialysis.
Yes, yes.
In our country, for our patients, we tend to reuse the cartridge like 3 to 4 times. In your study, were these patients on a new cartridge, or were they, or
yes.
were the cartridges reused?
Reuse is not allowed in Belgium, and they are all new cartridges.
So new cartridge. Okay. Thank you.
Okay. Next question.
Yes, thank you very much. My name is Saleh Khaisi. I'm from Brussels. So for the first speaker, thank you for the presentation. Great work. You said that HDX is better in morbid mortality than high flow hemodialysis. But I didn't see really a prospective trial that compared the two techniques. You said that there's a study comparing HDX with HDF with 40 patients. So would you comment on that, please?
Yes, of course. There is only 2 studies that compare high flash with expanded hemodialysis, and you are right that there is not a lot of evidence in mortality, a very important endpoint. But we have a lot of evidence about studies that compare the decrease of different molecular weights, and there is no doubt that expanded hemodialysis decrease more medium and large molecules when we compare between high flash hemodialysis. We have not this evidence in hemodiafiltrations. We need more evidence. There is some studies that says that they decrease similar way, and other that the largest molecules are decreased more with HCX and another with HCF. I think it's very difficult to say with just to measure the molecules, because it's not the same dialysis that we can do, for example, one hemodiafiltration with 30 liters of convective volume, 5 hours, for example, and another with 20 or maybe less. But you are right, there is not many studies in mortality to compare one and another.
Okay, Thank you.
Thank you.
Are you aware of a study that's coming comparing HDX with high flux hemodialysis, searching for hard endpoints like mortality and morbidity in the future or ongoing?
Well, I think that, in my opinion, that now we mustn't compare with high flux hemodialysis, because we now have evidence that the best treatment nowadays is the hemodiafiltration. So I think it's better to compare, not to do many studies and to generate evidence that we have now, and we must look longer and say we must compare with the best treatment, that is hemodiafiltration. Is my opinion. I think that it would be better.
Thank you very much.
Thank you for your question.
Next question, Professor Wissing.
Yes, hello. Congratulations, very nice symposium. I have two questions for Professor Elot. The first, very interesting study correlating the anticoagulation dose with quality of life. My question would be, did you control for the catheter use? Because often patients with a catheter have a higher dose of anticoagulation. They're also older, and that might have been a confounding factor in the analysis, because they might have a lower quality of life because of these factors. And the second question is, did you try the Solacea filter in combination with a citrate dialysate to see whether you can completely avoid anticoagulation in this setting?
Mm-hmm. Thank you for your first question. We checked, but there was no differences, well, in the outcome from the catheters versus the fistula.
And the dose of heparin did not differ between
that wasn't, I'm not sure anymore.
They get a higher dose, and that this might explain why some patients with a higher dose might have lower quality.
But I also must say that in all our studies, we only include patients of which we know that they have a well-functioning catheter. Okay. Because, we are looking at the hemodialysis, but from our first studies, we know that the outcome of the dialyzer was sometimes only bad because of the catheter, which was not functioning. You have a lot of alarms, blood standing still, and so you didn't get a clear, not a clear view. So, but in the study with the 70 patients, they had well-functioning catheters as, Okay.
And because we showed that when you combine an Evodial filter with a citrate dialysate, you can completely avoid anticoagulation. Did you try this with the Solacea membrane?
No, we always work with bicarbonate dialysate. We have done studies also with the Evodial versus other membranes, and then with, of course, zero anticoagulation, the Evodial was superior, but we did not directly in the same patient group check Evodial versus Solacea.
I can add to that we also did a study using Solacea plus citrated dialysate, and it functions approximately equally well as the combination of Evodial plus citrated dialysate. So it really is an alternative option for heparin-free dialysis with a success rate of around 94–95% of treatment sessions. Next question, please.
Okay. Thank you for your very interesting presentation. I have two questions. The first, did you have any trial comparing between the two kind of dialysate, bicarbonate and citrate, regarding the thrombogenicity, etc.? And the second question is the thrombogenicity is influenced by the number of reuse, because dialyzer reuse is still very common in our country.
Yes.
I would like to know that.
Yes. Relating to the question, we compare acetate, 4 millimoliters from acetate with citrate from Baxter with 1 millimoliters and without acetate. This was the comparing in our study. Sorry that many data and little time, so I couldn't explain very well. Thank you.
And the thrombogenicity?
Could you repeat the second?
The thrombocyticity is influenced by the number of reuse or not? Reuse, dialysis, reuse.
The reuse of dialysis, yes, but we are not reusing dialysis.
Okay.
Yeah.
It's not allowed in the whole of Europe to reuse dialyzers for dialysis. So it's all single-use dialyzers in Europe.
Thank you.
I have another question regarding the mother trial. You used it one single dialyzer in that study. Do you think that these results are representative for dialyzers with similar characteristics?
It's a very interesting question. In the mother study, as you can see in the number, because I put the number of the study, mother, the THE is from Terranova, that was the dialyzer we used in this study. And the other dialysis were the dialysis that people use habitual in their dialysis unit. We have Elixon, polyamide, polynephrine, also Elixon, and so on. So different dialysers. And I think that it must be similar, and the results could be conclude because it's like a real-life study. Regarding the medium cutoff, I must recognize that we need a definition about what a medium cutoff means, because it's necessary to know exactly the inner diameter, to know the cutoff of the dialysers. So I think that we can extrapolate, but we need exactly a definition that what means a medium cutoff. Very similar that we have many years ago, that what was hemodiafiltration, because the retrofiltration was also in the high flash hemodialysis. So I think it will be very interesting to know exactly the amount of retrofiltrations and exactly the medium cutoff, and maybe the number of fevers too.
Okay. We also have a question from the online audience, Christian Daugard-Peters, to Professor Eloot. What is your view on the use of pre-dilution HDF without anticoagulants in a patient with bleeding risk, for example, after surgery?
In such cases, we, in the past, we used EVODL dialyzers without any anticoagulation and did that in pre-dilution. But after our studies of the different dialysis modes, we are not doing that anymore in pre-HDF, but actually in post-HDF. I must say that the study might have been a bit underpowered, but I think not seeing any difference already shows that it's not that post-HDF would be too bad, I would say. I think using the Solacea would be an option that is as good as the EVODL.
Yeah, and in addition, over the last 10 years or so, there were a number of studies, including the HEP0 study, in which the control arm was pre-dilution, either intermittent or continuous, and it was had not a very high success rate, around 60%, and I think that there are currently a number of alternatives that have a higher success rate for those patients. So I'm looking around. I don't see any additional questions. So
can I have a comment?
Yes, sure.
Thank you. I think that for dialyzing patients without heparin, that is really very complicated. Maybe we must associate different solutions, maybe a less thrombogenic dialysers and also citrate. Why not? I use this, I combine both in my hospital, and sometimes also saline flashes, because it depends on many things. It depends on the hematocrit of the patients, if they take some pills like antiaggregant. So I think that the best way would be to combine many different tools. Thank you.
Okay, that's almost my own conclusion. I think we had a really interesting symposium with a lot of information on different options to individualize treatment. We had some information about a potential alternative for patients that might not tolerate HDF, that HDX might be an alternative. For patients at high risk of bleeding, we have a number of alternatives, and as exciting new technologies that might provide more insights into how anticoagulation actually happens, and this is very promising for the future. With that, I would like to close the session and thank you all for your attention.